this session. Uh, the rules are that each paper is of 5 minutes duration, and there's no change of the presenting author is allowed. The first presentation is Dr. Manishka. The next presenter is Dr. Jonathan. Is he here? Yeah. After that, Sri Kirti Ram. Please start presentation.
Good morning, everyone. Myself, Dr. Manshika. My topic of presentation is capillary ferning on fundus fluorescent angiography, unveiling clinical phenotypes, and treatment response in posterior uveitis. Capillary ferning occurs due to excessive capillary or venular leakage in retinal vasculitis, peripheral fern-like leakage, and is an adjunctive indicator of uveitis activity. It can occur in both non-infectious and infectious inflammatory disease. In our study, we compiled 13 cases which showed capillary ferning and analyzed their clinical phenotype and treatment outcomes. Capillary ferning, according to Julian et al., implies Behçet's, but it's not a hallmark to Behçet's alone. Prithvi et al. Described an venular preference, and Dhurani et al. Showed peripheral capillary closure in TB and sarcoidosis. Our hypothesis is that venular inflammation leads to aggregation of inflammatory exudates, thereby causing occlusive episodes in small venular and capillary beds, causing backflow and extravasation of the dye, which leads to fern-like pattern. It's a retrospective analysis of 13 patients who have capillary ferning in FFA were analyzed. The history of presentation, systemic risk factors, previous treatment history, ocular examination, ocular investigations were reviewed. In FFA, we classify the capillary ferning into peripheral ferning defined by the area outside the vascular arcades depicted by the picture, and diffuse ferning not involving the macula, that is ferning present posteriorly crossing the vascular arcades not involving the macula, and diffuse ferning involving the macula. Our results, the mean age of presentation is 22 years with male and bilateral preponderance. The mean logMAR at final visit showed a significant visual improvement. The predominant etiology were Behçet's and TB, followed by intermediate sarcoid uveitis and Eales disease. The most common complications we encountered were secondary glaucoma and PSCC. Peripheral ferning and diffuse ferning involving macula with the most common presentation, followed by diffuse ferning not involving the macula. The visual acuity at presentation versus the FFA findings, more than 80% of them in diffuse ferning involving the macula had vision less than 6/60, and those who had good vision at presentation are in peripheral ferning and diffuse ferning not involving the macula group. Final visual acuity versus the FFA findings, more than 60% of those who in diffuse ferning involving the macula had poor vision less than 6/60, followed by peripheral ferning and diffuse not involving the macula had vision more than 6/60, that is they have good visual prognosis. 60% required immunosuppressants and 38% required biologicals. Clinical activity at the end of follow-up, 60% were inactive in biologicals group, and 88% at the end of the follow-up who are in immunosuppressant with steroids are active at the end of the follow-up. This is a representative case 1, a 13-year-old with right eye blurring of vision since 6 months, and she had previous episodes of blurring and redness. She had past history of receiving steroids, azathioprine and MMF, and subtenon injection. His vision in right eye is 6.9 and left eye is 7.5. IOP is normal, and both the eyes showed anterior segment reaction, and fundus also showed vitreous haze grade 2 with peripheral vascular sheathing. FFA at the late phase had diffuse capillary ferning with disc staining at presentation. Her blood investigation showed HLA-B51 positive, and other investigation were inconclusive. And since the patient had recurrent and recalcitrant course, we switched to adalimumab 40 mg with prednisolone 5 mg per day, and at 1 month follow-up, her reactions were less, and there are no retinitis, and in third one follow-up, she had good visual improvement, and in the FFA showed reduction in capillary ferning at the late phase. This is a representative case 2, a 21-year-old presented with both eye blurring of vision since 1 year, previous history of right eye ERM surgery, and the patient was already on mycophenolate and steroids. Vision in the right eye is 660 and left eye 612. On examination, right eye anterior chambers were quiet and posterior chambers were also quiet. Left eye had vitreous cells with posterior subcapsular cataract. Fundus and OCT showed both eye cystoid macular edema. And FFA at first visit showed in late phase there is a peripheral capillary ferning with disc staining, and and her blood investigations were inconclusive, and she was referred to rheumatologist and was started on tofacitinib 10 milligram. And on 3-month follow-up, her visual acuity improved to 636 in the right and 69 in the left eye with a quiet eye. And the fundus examination showed reduction in cystoid macular edema in both the eyes. But there is persistence of CME. Since the tocilizumab acts well in uveitic macular edema, rheumatologist's opinion was sought, and it was switched. And at third month follow-up, her peripheral capillary ferning reduced with reduction in cystoid macular edema. Our take-home points are we conclude that capillary ferning occurs in papillary ferning in posterior uveitis occurs where disease course is severe, and diffuse ferning with macular involvement had poor visual prognosis compared to the peripheral ferning. An early introduction of immunosuppressive and biologicals in patients with significant capillary ferning causes good resolution of capillary leakage and visual improvement. Thank you.
So Manishika, you were having that tuberculosis also as an etiology.
Yes, sir. Yes.
So have you started ATT in those patients?
Yes, yes, sir. Along with ATT, immunomodulators and biologicals.
Okay. And any different pattern in those patients of TB? Because the pattern of that the disease in the base is different from that.
So they had retinal vascular recalcitrant and recurrent. So we can switch over to immunomodulators and biologicals according to the patients.
And any other investigations? What investigations you have done for these patients?
Sir,
Whether any patient was presenting like that frosted branch angiitis or anything? No.
No, sir.
So have you ruled out virus or not in these patients?
Yes, sir. We have ruled out viruses also.
So what you have done?
We have done CBC, we have ruled out for TB, chest X-ray, quantiferon TB gold, sarcoidosis, ACE test.
Have you done AC tap or vitreous tap in those patients to rule out virus?
Yes, sir. AC tap was done.
AC tap was
AC
done.
tap was done. Thank you.
Next, Dr. Jonathan. After that, Dr. Sri Kirti.
Good morning, everyone. I'll be presenting on my paper is the treatment of non-infectious pediatric uveitis grueling for an ophthalmologist. So at our clinic, 7% of our uveitis patients fall in the pediatric age group, with complications occurring in 30s to 60% and legal blindness in 7 to 23%. The reason why this is so high is children are often asymptomatic because they are unable to express their symptoms. In addition, the difficult ocular examination, treatment non-compliance, and the need for long-term follow-up make treatment a difficult task. Amblyopia further contributes to a poor visual prognosis. So the aim of our study was to determine treatment outcomes of non-infectious pediatric uveitis in the era of immunosuppressants and newer biologicals. We analyzed retrospectively clinical records of our patients from February 2023 to April 2023. We followed a step-ladder approach in treatment of all our patients. First, we would start with topical and systemic corticosteroids. If it was not sufficient, we would switch to immunosuppressants, the first being methotrexate, the second option being MMF. If they were not effective, we would switch on to adalimumab. And if adalimumab was still not effective, our last defense was cyclophosphamide. We studied a total of 27 pediatric patients, and for comparison, we studied 27 adult patients as well. The pediatric patients, majority were female, and the most common uveitis was a bilateral non-granulomatous uveitis, falling mainly in the intermediate anatomical classification, followed by then anterior and panuveitis. The most common etiology was sarcoidosis and idiopathic cause. When they presented to us, we found that pediatric patients were mostly visually impaired with a vision less than 6/18 in 41%, while in adults it was only 22%. In the pediatric age group, the most common complications were at presentation were band-shaped keratopathy, complicated cataract, and posterior synechiae. While in adults, we had only one patient with band-shaped keratopathy, and it was not involving visual axis. We found that in adults, most of them responded with the first immunosuppressant used, while in pediatric patients, we had to switch on to a second immunosuppressant. Overall, when we started immunosuppressants, the mean time from presentation to starting was 7.34 months. If we switched on to the second immunosuppressant, it was 19.38 months. And if we used a new biological, it was at 19.5 months. We started immunosuppressed cases. So in our study, 4 children needed to be stepped up to adalimumab, and in 2 of these patients only inflammation was well controlled. In the other, we had to switch to cyclophosphamide, and in another patient, they still had active uveitis. So our study highlights that we can reduce corticosteroids, thus avoiding the long-term side effects in children. The poor visual outcome was due to cataract, cystoid macular edema, and band-shaped keratopathy. IOL implants also went into subluxation optic capture in children more than adults. So basically what our study wants to point out is that we need to be more aggressive in treatment of pediatric uveitis. And with the help of more drugs being studied, such as rituximab, golimumab, and JAK inhibitors in pediatric uveitis, hopefully we'll be able to achieve better and longer duration of control. Thank you.
So, how many of your patients have achieved complete remission? Because you have told that there are patients who are having still some activity. So I think that the total purpose of giving those immunomodulators or biologics has not been satisfied.
Yes, sir. Because we felt that we were starting immunomodulators a bit late, like 6 months, maybe too late. Maybe we need to start earlier, especially in children. We should not wait too long and be afraid to start immunomodulators.
And when you have decided to start that biologics or immunomodulators?
Yes, sir. In our study, we were starting at around after at least 20 months, almost a year after presenting to us. So we feel that we should start earlier on biologics.
And in your that treatment algorithm, you have mentioned that you have started kids on either prednisolone acetate eye drop or difluprednate eye drop. So what I think that difluprednate is very much notorious to raise IOP, particularly in kids, and it has been seen that about 30% of kids, they have a very high chance of getting high IOP. But in your complication aspect of those pediatric uveitis patient, I haven't seen even in a single case of raised IOP.
Yes, sir. We were monitoring the IOP, sir, at all cases. So our patients had not developed raised IOP. At every visit, we were monitoring, sir.
And how many patients were there? The etiology-wise, how many patients were there of HLA-B27 or GIA-associated uveitis?
So in HLA-B27 was mostly seen in the adults, sir. So that was around 30%.
GIA patients, I am very much particular about GIA patients.
GI patients were around 30%. We have found more number of patients having pars planitis compared to GIA, sir, in our study.
No, GIA is associated with HLA-B27,
yes,
and
sir.
I think that should be ruled out because GIA is very much notorious.
Yes, sir. Yes, sir.
And one more thing I have noticed that what age you have taken for that pediatric subset?
The youngest was 7 years, sir. From 7 years up to
No, the
18.
cutoff value.
Less than 18.
I think it is 16. If we talk about pediatric uveitis, it is less than 16 years.
Okay, sir. Okay. Yeah, we took up to 18. Yes, sir.
Oh, actually, it is. If you will go with that, the book that uveitis that written by Stephen Foster, you will see that the pediatric uveitis, they describe it as below 16 years.
Yes, yes, sir. That is true. That is
Okay, thank you.
Yes, sir. Thank you.
One question. After this study, has it changed the practice pattern in pediatric uveitis? Now, are you starting immunosuppression in the first instance along with the steroids, than waiting for the steroids to not respond and then start immunosuppression? Like in Behçet's and VKH, we do that for adults. In
Yeah.
pediatric, has it changed the?
Yes, sir. In pediatric, at our first visit, we'll always start with oral steroids only, sir, and see the response. Then by their second or third visit, if we see that there's still active inflammation, we will start, sir. We will
But
not wait.
Not at the outset. You will not start with the immunosuppression because we know that a lot of patients will not be able to control with only steroids.
Yes, sir, but still not at the outset, sir, because we still because immunosuppressants still have their own side effects, sir. So we just want to see that if they are responding to oral steroids or not.
Good morning. 51 was negative. Other presentations of syphilitic retinal vasculitis can include ground glass appearance of the retina, acute syphilitic posterior placoid chorioretinitis. The limitations of this the report was like a second retesting was not done, like FT antibodies was not done because specific test was positive. And we asked for a lumbar tap, which was advised against. Take-home messages, miliary retinal lesions seem to involve full thickness of the retina, which is a characteristic of ocular syphilis. Delayed presentation and diagnosis of the disease is another factor which contributes to the poor visual acuity. Syphilis should be ruled out and should be tested for an infectious panel of investigations. Ocular manifestations of syphilis can cause gross visual impairment. It can mimic other diseases of the eye. Hence, syphilis should be ruled out, even though if medical history does not initially raise suspicion. Thank you, sir.
So, Dr. Shri Kirti, in
Yes,
your
sir.
patient, you have done RPR and TPHA,
Yes, sir.
and your RPR was negative and TPHA was positive.
Yes, sir. But treponemal tests were positive, sir.
Yeah.
The non-treponemal tests were not.
That was negative.
Yes, sir.
So that TPHA can be false positive.
Yes, sir.
There are conditions where that TPHA can be false positive, particularly in the patients of biliary cirrhosis and other things. And if that ocular syphilis is there, it is considered as a neurosyphilis.
Yes, sir. That's why we had asked for a CSF, but CSF analysis, but it was advised against, sir. We wanted to rule out neurosyphilis also because secondary, whenever syphilis presents in these elderly females, we suspect it is usually linked to neurosyphilis only. And we had asked for, but the doctor had advised against. No need, he said.
And any other systemic clinical feature?
Systemic lymphadenopathy was ruled out, sir.
The
And,
Tedlenberg test.
Sir?
Tedlenberg test.
The gate.
Yeah.
Probably
And that ANA was also positive.
AN also was positive, sir.
SLE is one.
SLE
Can have false positive.
could be a false
Yeah.
positive, sir.
Because that collagen tissue disorders, in those patients you can
Connect-
have a false
In-
positive TPHA.
Yes, sir. Yes, sir. We thought so, sir. But what happened was when we got the second testing done, there was a reduction in titers, sir. 1:1280 came down to 1:320. So there's almost 3/4 of the reduction of titers in literature, which suggests that it is if it responds, if syphilis responds to our treatment, there will be a reduction in titers, sir.
And the main thing that RPR was negative. So if
RPR
it was
was
positive, then we can consider that okay, RPR is positive, TPHA is positive. It may be the recurrence of latent syphilis.
Latent
But that
syphilis.
RPR was negative.
Yes, sir. That was only.
And once that syphilis is there, that TPHA once positive is always positive for the lifelong.
Yes, sir. But she came back with a recurrence, so we thought it had reactivated.
Okay.
Okay.
Thank you.
Thank you so much.
Anushkita. After that is Shubhamita.
Good morning, everyone. Today I'll be presenting my paper on polymerase chain reaction for Mycobacterium tuberculosis genome in granulomatous anterior uveitis, analyzing 51 eyes. Granulomatous anterior uveitis is a common uveitic entity in India which can be due to tuberculosis, sarcoidosis, and other systemic or immunological causes. Laboratory tests like MON2, quantiferon TB gold, HRCT chest, serum angiotensin converting enzyme, etc. can have been used to distinguish between sarcoid, tubercular, and other etiologies. Polymerase chain reaction in the last 2 decades has become an important diagnostic tool and can detect Mycobacterium TB DNA from the intraocular fluid. However, utility of this test in granulomatous anterior uveitis in Indian scenario has not been evaluated yet. We aimed at determining the utility of PCR of Mycobacterium tuberculosis in establishing the diagnosis of tubercular anterior uveitis and to correlate the results of PCR with that of other tests like HRCT chest, TB gold test, and MON2 test. Ours was a retrospective cohort study which analyzed 51 eyes of 38 patients who presented with granulomatous anterior uveitis to us, and we did PCR for MTB genome 1, AIOC2024 and MPB64 in those patients between January 2016 and December 2022. We included the patients who presented to us with clinical features like mutton fat KPs, iris nodules, broad posterior synecdoche, and excluded all the other non-granulomatous uveitic entities. Statistical analysis was performed using Microsoft Excel and SPSS statistics tool. These were our parameters. Coming to the results, most of our patients fall in the age group of 30 to 40 years with a mean age of 43.21 plus minus 18.63 patients, with most of the patients being female. We had found mutton fat KPs in 60.5%, broad PS in 73.7%, and iris nodules in 15.8% of our patients. We performed PCR and we found that 63.2% patients showed a positive PCR results, out of which a combination of IS6110 and MPB64 genome showed the highest positivity, that is 65.2%, and this underlined the fact that if we include these two genomes, in literature also it is there that it increases the chances of positivity of PCR. Here is the agarose gel electrophotogram showing the PCR results in one of our patients. Here it shows that how it was positive for both MPB64 and IS6110. We also did real-time quantitative PCR in this patient and found 26023 copies per ml of MTB DNA. Coming to the correlation between the tests, we found that in 4 of the patients who had negative MON2 test, PCR was found to be positive, and in 3 patients who had positive MON2, PCR was negative in those, and it was statistically significant. And PCR and HRCT results also showed weakly positive correlation. However, it was not statistically significant, and PCR and quantiferon TB gold also showed a significant correlation between these two. So we treated the patients with ATT, and most of the patients responded to ATT and topical as well as oral steroids with and without immunomodulators. These are one of our patients showing positive PCR post and pre and post treatment. And we also found excellent results in 66.7% of our patients. To conclude, we can say that PCR for MTB genome is a valuable tool in diagnosis of tubercular anterior uveitis. PCR can be positive even in cases of negative MON2, quantiferon TB gold test, and HRCT in granulomatous anterior uveitis. A positive PCR can help us clinch the diagnosis of TB uveitis at an early stage and guide us in starting specific treatment, that is ATT. However, in our study, we saw that a negative PCR of aqueous aspirates doesn't always rule out the chances of tuberculosis etiology. But we are fortunate to have a lab in which we rule out most of the false positive results, as we have got a negative control, and also we have got a negative and a positive, false positive, and a false negative control also. So we are fortunate in that, and in that aspect. But when we generalize, we can say that negative PCR aqueous aspirate doesn't always rule out the chances of tuberculosis etiology in anterior granulomatous uveitis, and however, it can help us a lot in those presenting with the clinical features we mentioned in this scenario, in Indian scenario, which is known to be endemic for TB. Thank you.
So did you have a control group wherein you diagnosed the patient to have a granulomatous anterior uveitis, you started the patient on steroids and they did not respond? As in, what will be the utility caseload-wise? Did you have a control group like that?
Sir, actually, in all our patients that were subjected to PCR, we were having a positive control as well as a negative control for all the patients. Fortunately, we have a dedicated PCR lab for the same. For every patient we send for PCR, we have a positive as well as a false positive as well as positive as well as a negative control for PCR. So thus we could rule out those cases as well.
My point is about the practicality and the utility of adding a big test like PCR in the routine diagnosis of a granulomatous anterior uveitis.
Yes,
So
sir.
what my point is that if we do not do a PCR and we go for the standard treatment of an anterior uveitis in a case of MAN2 negative cases, so how does it impact the outcome of those cases? So do you have a control group like that?
Actually, we didn't have any control group, but that our study is about that only. That we saw that the utility of PCR, how the PCR is being important in those patients who had a negative Montauk result and a negative HRCT result. Still, it responded to anti-tuberculosis treatment based on the PCR results actually. So this is what our study is actually about, that we want to emphasize on the utility of that
No,
PCR.
but my question is that what was the rationale behind starting you had your rationale behind starting the ATT.
Yes, sir.
My point is that do you have a group wherein you have a standard diagnosis of a granulomatous anterior uveitis?
Sir,
Your
we
test, your
had,
routine
sir,
tests are-
first of all, yes, sir. Yes, sir.
Let me complete my
Sure,
question.
sorry, sir.
So you have a granulomatous anterior. Your paper is fantastic. Don't worry about that. My question is that in a case of a granulomatous anterior uveitis where your routine tests that you usually order for are negative, and you start the patient on steroids and the patient doesn't respond, and then you go in for an ATT.
Yes, sir. So my rationale for this, our rationale was that first of all, we chose very specific patients who presented with us to our clinic with granulomatous anterior uveitis features with mutton fat KPs, anterior uveitis features, broad posterior synechiae, and iris nodules. So we ruled out two granulomatous etiologies. So first is tuberculosis, second is sarcoidosis. Some viral etiologies were there. These are the main infectious and non-infectious etiologies for granulomatous anterior uveitis. So first we ruled out sarcoidosis and TB and viral etiologies by doing first of all serum AC also we did, and we did Montauk, HRCT, and PCR for viruses also we did sir. Like whenever we send for the patients for PCR, we also included viruses also because it is one of the etiologies for granulomatous uveitis. So these are so based on our clinical diagnosis as well as the results, we started on ATT. So if there was a strong clinical suspicion, and also we take chest physician opinion also for all our patients. So in collaboration with our clinical suspicion, the laboratory test, and the chest physician's opinion, we started our patients on ATT, and also the response in our patient again helped.
All right, let me reframe my question. There's a patient of granulomatous anterior uveitis. You have broad posterior synechiae. You have mutton fat KPs. You have everything that points towards a granulomatous etiology, and your ACE levels are false positive, and your MAN2 is negative. What would you still go for a PCR?
Yes, sir. Based on the clinical presentation, and since India being a TB endemic country,
India
go
is a
for.
developing country and economically backward country with less of availability of PCR, and we are less fortunate. We're not
Yeah,
as
I
fortunate as
agree.
your institution. So that was my
I
entire
agree,
point about
sir,
inclusion
actually,
of utility of PCR in the routine diagnosis of granulomatous anterior uveitis, just based on a Mantu positivity? Because it's a that was my entire question.
I agree, sir. We had been fortunate that for our institute it was more feasible because it was a referral center and everything else has been tried. So that can be one of the limiting factors in our study. But yeah, we need to do.
Only after
Yeah.
everything else has been tried. You said it yourself.
No, not in every case, because but yeah, some cases they were diagnosed as granulomatous, but they were not responding to only oral steroids and IMT. So we did go a step ahead and did PCR. But yeah, I agree that this study needs to be done on a broader level to establish the fact that PCR is actually very helpful in granulomatous anterior uveitis as well. And there is one study, that CORD study. They have also mentioned about the various that how based on how previous
It sure is helpful. PCR
Yeah,
of
yeah,
course is
definitely,
helpful.
definitely.
I'm not saying it's
Huh.
not helpful. All I'm saying is, what is the practicality of inclusion of this test?
Yeah,
And what is
like
the
being a costly
versus
test.
comparing it to its feasibility, what is the practicality of including this test?
Yes, sir, I agree. We can include this test based on practicality. We can include this test only when all the other tests are negative and we have a strong suspicion of ocular TB. And since we don't have any other cheaper options, unfortunately, so in those cases we can go for PCR. If we want to be selective, we can go for those patients who are having a negative Montauk, a negative QTB, a negative HRCT, but still the ocular picture is very suggestive of ocular TB. Then in those patients, and considering the
I think
In
that
my head, I think if I would have been you, I would have gone for a PCR in cases which are not responding to a normal treatment.
Yes, sir, that is what. In those cases, first, definitely we'll try to do oral steroids, and we will try giving. And if they are not responding, because sarcoidosis also can have a similar presentation, definitely, as I mentioned before. But yeah, after ruling out everything, this can be our go-to step, next step. Thank you, sir.
okay. So I think that you should order that PCR for MTB only when the patients are not responding to the treatment or your patient is getting worsened, and you yourself has landed into the trouble by quoting that COTS 1 and COTS 2. Those are totally different things, and I think you should go ahead. Okay, so we will call the next one because we're not having so much time. We will
Thank you,
discuss it
sir.
outside the that hall.
But you had a very, very nice paper, Dr.
Thank you so
Anshu
much,
Mehta.
sir. Thank you
Well
so
done on
much,
that.
sir.
So the next one is Subhamita Guha, and she's presenting clinical profile and management of ocular TB, presenting in a tertiary eye care center in North UP.
Good morning, everyone. So, tuberculosis is a common global burden amongst infectious disease. India accounts for 27% of tuberculosis cases across the globe, and UP is a highly TB-prone belt in North India with highest contribution of 21.58% cases in India. Prevalence rate in India is 312 and 427 in UP per thousand population. It occurs secondary to exposure to Mycobacterium tuberculosis due to direct infection or an immunological response. It is devastating and potentially blinding condition if the patient is ignorant to the initial symptoms. So timely intervention and adequate treatment are of utmost importance. In all cases, ocular TB is treated as active TB disease. So here we evaluated clinical profile management and outcomes of ocular tuberculosis. This was a retrospective observational study where we studied records of patients who were started on ATT based on presumed ocular tuberculosis from August 2021 to April 2023. We evaluated 2 to 7 eyes of 163 patients with ocular TB who were initiated on ATT, and unilateral cases were in 99 patients and bilateral were in 64 cases, and in majority of the cases were present in female in either unilateral or bilateral. The mean age of presentation is 36.8 years, and initial best corrected visual acuity was 20 by 125, that is logMAR 0.8 during presentation. The most common ocular manifestation was intermediate uveitis followed by panuveitis, retinal vasculitis, and multifocal choroiditis. And amongst other associated findings, we have complicated cataract followed by vitreous hemorrhage and CME. Complicated cataract and CME was most common in panuveitis, whereas vitreous hemorrhage was most common in retinal vasculitis. This slide shows an array of varied clinical ocular manifestations in ocular tuberculosis. Same goes on here as well. And here also we can see some cases of untreated retinal vasculitis going into TRD. And in picture number 1, we can see occlusive retinal vasculopathy with CME. And in the third picture, we can see skip vasculitis. Amongst adjuvant treatment, oral steroids was started in almost 98.15% of the patients, followed by PST was given in 11.14% of the patients, and PRP was done in 6.13% of the patients. So out of 163 cases who were started on treatment, 104 cases, that is 128 eyes, completed the treatment, and 59 cases, that is 99 eyes, were lost to follow-up. And out of the resolution status, 97.65% of the cases had complete resolution, and 2.35% of the cases were not resolved because of non-compliance to drugs. And the post-treatment base corrected visual acuity was in between 2030 to 2040, logma 0.26. And in the post-treatment sequelae, the most common was complicated cataract, followed by ERM formation and cystoid macular edema. And in one case, we have after multifocal choroiditis resolution, we had CNVM, which was treated with Avastin injection. And in the last OCT, we can see the post-injection condition of this patient, and that amongst the treatment-related complications, secondary glaucoma was most common, and majority of which resolved by medical treatment only. And amongst the side effects of ATT, headache was most common, and on long-term follow-up, recurrences was most commonly seen in multifocal choroidal granuloma, followed by multifocal choroiditis and serpiginous choroiditis. In another study by L. Ganvan et al., there they found the most common clinical presentation was non-granulomatous anterior uveitis, and the age of presentation was between 41 to 60 years, which was in contrast to our study where we had the mean age of presentation was 36.8 years, and the most common presentation was intermediate uveitis, which is also in contrast to another study by Sultana et al., where retinal vasculitis was most common, and we had recurrence rate in multifocal choroiditis and serpiginous choroiditis. And similarly, post-ATT course, none of the patients showed any ophthalmic manifestations like ethambutol toxicity, color blindness, and most adverse drug reactions were CNS related, similar to the other results studied as showed by other studies. Till date, very few literature exists with detailed comparative analysis of clinical TB, and so proper patient compliance for drug and long-term follow-up and public awareness regarding ocular TB course and consequences of delaying treatment can prove to be highly beneficial in the long run. Thank you.
How many patients in your study presented with a CNVM? Did anybody present with CNVM?
Sir, later on, after treatment, only one patient had CNVM. And
was it active?
Yes, sir.
And what was the, and how did you treat that again?
It was treated with intravitreal Avastin injection.
Avastin.
Yes,
Right.
sir.
Do you have any data showing any kind of improvement of CNVM with an ATT treatment?
No, it showed CNVM occurred after healing of the multifocal choroiditis, not during ATT initiation.
Oh, all right. Okay. All right.
So your topic was ocular tuberculosis.
Yes, sir.
So is there any case of that orbital tuberculosis or the tuberculosis of adnexa?
Sir, in our institute, we didn't come across such patient which presented with adnexal tuberculosis.
I think it's a good paper, you should publish this, but with that tuberculous uveitis, I think that please don't use the word ocular tuberculosis, because ocular tuberculosis is a very vast word, and one reference that should be there will be an article, that landmark article by Professor Amod Gupta sir, published in Survey of Ophthalmology 2007. I think it is easily available. I think you should go ahead with that. Now coming back to your paper. So, in how many patients of that tuberculous posterior uveitis, means tuberculous choroiditis, how many patients you have seen a solitary granuloma? How many patients you were having that miliary tuberculosis type of picture?
Miliary tuberculosis on
Yeah,
thorax.
because you have mentioned that clinical profile and management. So I just want to know that how many patients were there,
Sir, we have only evaluated the.
and what was the commonest presentation of that tuberculous uveitis?
The most commonest presentation was intermediate uveitis only, followed by multifocal choroiditis and choroidal granuloma.
And what were your treatment protocol based on which? How you decided that you will go ahead with this ATT?
Yes, sir. So we asked the patient to taste for MANTU and X-ray chest or thorax in IGRA, and also we ruled out sarcoidosis.
I think IGRA is not very much reliable because I think that ICMR has banned all the serological tests for tuberculosis in 2011, I think, if I'm not wrong. I think that now we are having the recommendations of COTS 1 and COTS 2. So I think that our treatment protocol should be based on that COTS 1 and COTS 2 recommendation.
TB go.
Okay, it's a good one. It's a very nicely documented.
Dr. Nijaka. Next will be Dr. Pratishta.
आपका ही है ना, आपकी 3 पीपीटी है, कौन सी वाली चला रहे हैं? 543 कौन सी वाली है?
Good morning everyone. Today I will be presenting on efficacy of adalimumab in non-infectious uveitis. Uveitis accounts for nearly 10 to 25% cases of legal blindness in developing countries. Resistance to conventional therapy, drug-related adverse effects pose a significant barrier to treatment. Biologics have emerged as a useful substitute for treating uveitis. Adalimumab is a fully humanized monoclonal antibody directed against TNF-alpha, thus inhibiting its activity. In July 2016, adalimumab became the first and only FDA-approved biologic after randomized controlled trial of Visual 1 and 2 study, which was followed by Visual 3 study. However, in a country like India, the use of biologic agents is feared to be more prone to developing infections. We conducted this study to describe the treatment outcomes of adalimumab in non-infectious uveitis. It was a retrospective observational study conducted between 2017 to 2023. Electronic medical records of all non-infectious uveitis patients were treated and the adalimumab were analyzed. We excluded patients with infectious uveitis and who had a follow-up duration of less than 6 months. Adalimumab was indicated in case of inadequate response to immunotherapy, intolerant to immunotherapy, and in some cases of primarily for the disease. The criteria for treatment success was control of inflammation, significant decrease in disease recurrence, vision improvement, and vision stabilization. Appropriate investigations were done whenever possible. Non-response to immunosuppressive was described as deterioration or persistent inflammation for 3 months with the use of immunosuppressive, and a decision to administer adalimumab either as first-line therapy or non-response to immunosuppressive was made after consultation with rheumatologists but primarily at the discretion of ophthalmologists. Appropriate statistical tests were analyzed and p-value of less than 0.05 was taken as statistically significant. To the best of our knowledge, this is one of the largest study in India involving adalimumab treatment with non-infectious uveitis, including 43 eyes of 26 patients with 14 males and 12 females. The mean age of adalimumab treatment was 18 years, and in the mean age of diagnosis of uveitis was 14 years. Anterior uveitis was diagnosed in 11 eyes, intermediate in 5, anterior with intermediate in 12, and pan-uveitis in 11 eyes. The mean duration of follow-up was 19 months in our study. Only 4 patients were there who did not receive prior immunosuppressive therapy. The most common cause etiology was a JIA, around 50%, which was followed by Behçet's, VKH, and the last being Crohn's disease. The course of uveitis in our study was complicated by various complications including posterior synechial cataract, bend-shaped keratopathy, CNVM, CME. 10 eyes, that is 23% eyes, required some surgical intervention due to the pre-existing complications. Adalimumab monotherapy was considered in only one patient. Oral steroids were stopped completely in 12 patients, and oral steroid dose could be reduced to 2.5 milligram per daily in 8 patients. Disease inactivity was achieved in 97% of the eyes at large stages, which was statistically significant, and disease remission was achieved in 74% of the eyes at third month. Visual acuity improved from 0.45 logMAR units to 0.24, which was statistically significant. Overall, vision improved in 21 eyes. It was maintained in 16 eyes and worsened in 6 eyes, which could be attributed to various ocular complications. Drug was discontinued in only one patient due to financial constraint, and relapse was seen in 2 patients. We did not encounter any serious systemic adverse effect in our study. Only one patient had raised liver enzyme who was concurrently receiving methotrexate. This is a photograph of one of our patients before and after treatment with adalimumab. The management of non-infectious uveitis is a dynamic field. Effectiveness of adalimumab has been well demonstrated in JIE-associated uveitis by sycamore and adjuvant trials. However, accessibility and affordability of biologic therapies in a resource-limited country like India remains a challenge, thereby limiting their use. Likewise, in one of our patient in a series, the treatment could not be continued due to financial constraint, and he had to be shifted to oral methotrexate, following which there was a recurrence. The EULAR consensus considered anti-TNF-alpha as a first-line agent for treatment of BASIS-associated uveitis. In our series, 3 patients with BASIS uveitis responded well. One patient with Crohn's disease and our patient required adalimumab. None of the patient in our study develops any severe complication, and adalimumab, even though it has a low rate of recurrence, relapse can still occur. In our study also, relapse was seen in 2 patients. There was some limitation. Our study had a small sample size. However, ours is a tertiary referral center that offers cases difficult to treat patients who frequently present late in the course of disease, and the mean duration of uveitis from symptom onset was 46 months in our study, and quantification of inflammation was not done. To conclude, adalimumab was found to be effective in the treatment of non-infectious uveitis by achieving disease remission, reduction in recurrence rate, with subsequent improvement in BCVA. The drug is safe and well tolerated, as we did not encounter any systemic infection or adverse reaction to the drug. It has a corticosteroid sparing effect. Thank you.
In how many patients you have started that adalimumab as a first-line therapy?
So for 4 patients.
That all the BASIS one. Okay. Have you tried infliximab in any of the patients who were not responding to the IMT?
No, sir. In this particular group of patients, we did not try infliximab. Most of the patients' response was good.
Okay.
So
So you haven't included the patients who were on infliximab?
no, sir. No. In these patients, they have never received infliximab. Also, the patients we have included.
So I think you can have a study comparing that infliximab versus adalimumab.
Yes.
Because that infliximab, the chances of recurrence are higher when you give the second injection because of the formation of antibodies against that infliximab. Methotrexate inhibits the production of those antibodies against that infliximab, but I think that adalimumab is really a very promising drug to take care of particularly the pediatric uveitis. And I think yesterday Professor Peter Makulski has presented his experience of that adalimumab in the Australian population. Yesterday only he was having a very nice talk. So I think that it's a very promising drug.
How many patients were still active post adalimumab? What subset?
Sir, the relapse was seen in only one patient, and that patient usually, we had to discontinue adalimumab due to financial constraint. Then we shifted the patient to methotrexate. After that, the patient developed recurrence, but then again we shifted the patient to adalimumab.
Okay.
Thank you.
Next question.
Dr. Pritisha Goswami.
Good morning, sirs. I'm here to present a case series of syphilitic uveitis in a tertiary care institute of Northeast India. So uveitis represents the most common ocular manifestation of acquired syphilis in the eye. There has been a resurgence in cases of syphilis globally over the past decade, and in 2015, the CDC reported a 7.5% prevalence of primary and secondary syphilis. Ocular manifestations occur in about 0.6 to 2% patients with syphilis at any stage of the disease. So in case 1, a 23-year-old male with diminution of vision of the left eye presented with BCVA 6/18 with AC cells +2, vitritis +2, and multifocal peripheral active vasculitis and chorioretinitis as seen in this picture. He had a history of exposure with a male partner and tested positive for RPR with a 1:32 titer, TPHA, and HIV. CSF analysis and MRI brain showed no signs of neurosyphilis, and he was started on the neurosyphilitic regimen of benzathine penicillin 2.4 million international units IM weekly for 3 weeks, and ceftriaxone 2 gram once daily for 14 days. He was also started with ART with cotrimoxazole prophylaxis and topical prednisolone and homatropin. And 1 month follow-up, his BCVA had improved to 6.6. Uveitis had resolved. Multifocal chorioretinitis lesions became pigmented and quiet, giving the salt and pepper appearance as seen in this picture. And repeat RPR titer was 1:8. In the second case, a 50-year-old female with painful diminution of vision of the right eye had BCVA of 6.9 with AC cells +3, posterior synecdoche. She had vitritis +2, mid-peripheral active retinal vasculitis with retinal hemorrhages, as we can see in this picture. And she had a past history of polymorphous skin lesions in forearms. She tested positive for RPR with 1:128 titer and TPHA, and she was treated similar to the first case. And her partner also tested positive and received treatment. And at 1 month follow-up, her RPR titer had reduced to 1:32. However, she had AC cells and some fresh retinal lesions, and she was restarted on oral doxycycline 100 mg BD for 14 days. At 2 months follow-up, her BCVA had improved to 6.6, and AC reaction, vitritis, and vasculitis had resolved. A case 3, 46-year-old hypertensive female with diminution of vision had BCVA of 6.12 with vitritis +2, peripheral retinal vasculitis with exudates and hemorrhages, who tested for RPR 1:2 titer and TPHA. She received benzathine penicillin and oral doxycycline as she was allergic to ceftriaxone. Her partner also tested positive and received treatment. And at 2 weeks follow-up, her BCVA had improved to 6.6 with vitritis resolved and no new lesions seen. A case 4, a 28-year-old HIV positive male with acute onset diminution of vision had floaters for 1 week with BCVA 636, AC cells +2, vitreous cells +2, vitreous haze +2 with early established disc edema. And he was treated similar to the first case. And at 1 month follow-up, his BCVA had improved with no AC reaction and vitritis and reduced RPR titer. Syphilis was diagnosed based on ophthalmic manifestations of uveitis in all 4 patients, aided by treponemal and non-treponemal serological tests, TPHA and RPR respectively. Dermatological manifestations were seen in 2 patients. HIV co-infection was seen in 2 patients. In 2 of them, the sexual partners had tested positive. All patients received the neurosyphilitic regimen with dramatic clinical improvement in signs and symptoms, and BCVA improved in all 4. At 4 weeks, RPR titer reduced 4-fold in 3 patients. This is a summary of the 4 cases. In conclusion, syphilitic uveitis is considered a great masquerader, posing a diagnostic challenge to all clinicians. Re-emergence of syphilis and its numerous ocular signs and symptoms make it necessary to keep it as a differential diagnosis for all uveitis. Due to the high incidence of HIV co-infection, all patients with ocular syphilis must be tested for HIV as it changes the natural course of the disease. Ocular syphilis requires neurosyphilitic therapy regardless of when it develops after primary infection. These are my references. Thank you very much.
Can you please show your summary slide?
Yes, sir.
So I think that in your 2 patients, that RPR titer was very low. And I think that was not significant.
So 1:2 we had gotten, and we consulted with, so we took a medicine.
I think 1:2 is not significant.
But then we were, because her partner also tested positive, it was, we went ahead with treatment.
So the partner was positive doesn't mean now that the other person was having that syphilis.
Yes, but
But
because she had
RPR,
ocular manifestation.
That RPR was Not
1:2.
significant.
Yes, sir.
Yeah.
That
And
was
again,
a.
that EPHA can be positive in so many conditions.
So we had
Was
a.
positive.
Yes, sir. We had a. In the department, we had discussed this issue, but because for ocular manifestations as well as by then we had also tested her partner, so it
And
had
have
been.
you followed up those patients who were RPR positive later on?
Yes, sir. So we had repeated the titer and.
So when you stopped the treatment, when
So-
you decided that the patient is now cured for
So,
syphilis,
so in literature, they mention a fourfold reduction in the titer as a significant reduction that is there. So these patients are still on follow-up. The last patient is lost to follow-up, sir. They are so doing well. There's no fresh lesions, no recurrence, and the titer at last visit had reduced quite significantly. It is so we did RPR only for those patients.
okay, thank you.
Thank you, sir.
You have a very nice collection of syphilitic cases, Dr. Pritisha, I must say. Good one.
Thank you, sir.
Good morning. My name is Dr. Arsha Russell. My topic is analysis of etiological pattern of anterior uveitis in a tertiary case, and there is no financial disclosures. Introduction: anterior uveitis is the inflammation involving anterior uveal tract. Anterior uveitis is the most common category with a variable prevalence throughout the world and is divided into iritis, anterior-cyclitis, and iridocyclitis based on standardization of uveitis nomenclature. Success of treatment depends on prompt diagnosis and timely treatment schedule. The total population prevalence of uveitis varies globally with an estimated prevalence of 730 cases per 1 lakh in India. Acute anterior uveitis is the most common presentation. Acute anterior uveitis due to HLA associated and other autoimmune disorders, idiopathic, infective, ocular causes, trauma, and masquerade syndromes. Chronic anterior uveitis usually bilateral granulomatous associated with systemic diseases. Common causes are juvenile rheumatoid arthritis, tuberculosis, sarcoidosis, postoperative fused heterochromic iridocyclitis. Aims and objective of the study: aim to study the etiology of anterior uveitis in a tertiary care center. Objectives: to determine the pattern of pattern of distribution of the disease, age-wise, gender-wise, acute or chronic type of presentation, unilateral versus bilateral. Materials and methods: study of all cases with anterior uveitis conducted at Uvea Clinic, Department of Ophthalmology. Study design: cross-sectional study period August 2022 to January 2023. Study population: inclusion criteria: all cases of anterior uveitis that presented to the OPD of a hospital. Exclusion criteria: active infective corneal pathologies. After obtaining informed consent from the patient's detailed history regarding the time of onset, progression, and various etiologies associated elicited. After clinical examination, the different cases were subjected to relevant laboratory investigation, a clinical diagnosis made, and appropriate treatment started. These are the clinical photographs of our patient. Results from my study: demography shows 77% of patients were males and 23 were females. More cases were between the age of 30 to 40 years. Bilateral cases are 7%, unilateral 93%. Etiology shows acute anterior uveitis is 84.6% and chronic anterior uveitis is 15.4%. Etiological distribution shows traumatic cases 70%, idiopathic 20%, infective 6%, autoimmune disorders 4%. Postoperative comprises of 5 cases. Causes of traumatic uveitis usually include, in my study include RTA 52%, assault 24%, sports injury 16%, iatrogenic 8%. Anterior uveitis in closed globe injury mainly due to contusion followed by superficial foreign body and lamellar laceration. Discussion: in this study, most common cause of anterior uveitis is traumatic followed by idiopathic, infective, and autoimmune related. Causes of trauma include RTA, assault, sports injury, and post-operative cases. This may be, because of my institution is a tertiary care center. More cases of traumatic cases were referring here, comparable with the study done by Sudha Madhavi KM et al. Conclusion: maximum number of cases were due to trauma, including surgery 70%, idiopathic constitute 20%, infective accounts to 6%, and autoimmune 4%. Anti-uveitis is a vision-threatening disease with a varied causes. In this study, trauma is the common cause of anti-uveitis, followed by idiopathic, infective, and autoimmune related. Thorough history, examination, and investigations are required in each cases to facilitate final diagnosis. Prompt treatment ensures good visual outcome. These are the references. Thank you.
So have you compared your results with, you have compared results with only one study?
Yes, sir.
I think-
Traumatic, etiologic traumatic is more common in my study, so I compared with one study.
So in that study, the trauma was the major culprit behind the anterior uveitis.
sir.
But I think there are so many studies from northern part of India to the southern part of India and the northern east part of India. Dr. Deepankar Das is having a very good study, then Dr. JB sir is having a fantastic study, then the PGI people are having the study. So I think that those studies are having different etiologies.
Yes, sir. Mainly due to idiopathic, followed by autoimmune and all.
And have you seen any change, because your study is in the post-COVID era?
Yes, sir.
So is there any significant change? Because what is the utility of this study when we are doing the study? What impression it is giving to the clinical fraternity? Whether that change is in that the pattern is different from the pattern we are seeing in the pre-COVID era?
That I don't know, sir. From my study, trauma is the most common cause.
No, that I agree, that trauma is the most common cause. That I agree, totally agree, because any study can have different causes. That's why we call it research, because we are searching again and again. Okay, but what I was pointing out, that is there any significant change in the etiology in the if we compare the pre-COVID era with the post-COVID era? I think we should do. I think it is important, because I have done a study where I have found that in the posterior uveitis per se, if I will say, I found TB more common as an etiological agent than toxoplasma. And one more thing that what I have noticed is that HLA-B27 associated uveitis is on rise. How come I don't understand? Maybe JV sir can tell us better. So thank you.
Thank you, sir.
So thank you so much, all the speakers. They are really very fantastic presentations, giving us insight regarding the management of uveitis. And believe me, it's really a wonderful world of cells and flavor. So thank you so much. And and who is the convener of next session? I would like to hand over the charge to that person. And who is the volunteer of this room, so that we can